As a practitioner, going all in on a diagnosis and treating and then expecting that it's going to work out without pressure testing it, it's just a gamble that I'm not willing to take with my clients, and I encourage everyone to do this one hack. Now, when you look at treating conventionally, the whole point of it is to narrow down an area, a potential injury cause, so that you can then help someone rehab their way out of it. Now, often, if you look at it, most of the time in diagnosis is spent on this differential process, this process of elimination, where you're confirming what you're seeing to be true based on how someone's moving, based off their pain and the presentation. Now, often what I see, and often what is taught at uni as well, is there's a lack of pressure testing this. Now, I've got a couple of examples to follow, but if you pressure test your theory before you actually go all in on a treatment, it's going to work out so much better for you. Now, let's give an example to this. If I had a client that came in and they had knee pain, and confirmation bias, I was like, that is the injury, that is 100% what they have, they've presented like this, but I didn't do any treatment, or I didn't add any exercises in to actually pressure test it to see if what I was doing was actually having a positive carryover. It's kind of guesswork. So I don't know if what I'm actually doing is going to carry over or not. So the better way to approach it is go, okay, well, I think it's a mobility issue in my knee. Quickly test it, release some of the muscles that you think are causing the tightness or pain, and then go through the movement that you've been performing that's been causing pain to pressure test it to see if it's made a positive effect. If you think someone has a lack of stability or a lack of control, add in some technical components to their lifts, like maybe a cue, or add in an exercise to upregulate, a muscle group or a pattern. Test it, put it into practice, and then go all in on it. Because quite often what happens is you've got pain, same knee pain, and you go in and you get, treated on the table, you get a ton of treatment, whether it's soft tissue, whether it's exercises, and there's so many inputs. It's very hard to actually figure out what actually worked. So anything that you're adding into the system, you want to pressure test first. Now, I want to make this very practical in today's episode. I want to show a couple of real life examples of a shoulder and a lower back and show how it's very easy to miss these things. Now, if we look at a shoulder, if you look at an active lifter, it's granted, they have a lot of muscle mass. They're going to have very dominant movement patterns, whether that's functional or dysfunctional, but these movement patterns that they have are strong. These movement patterns do a lot of work for them. So what we want to do is have a look at how they're moving, have a look at the range, and go, okay, well, here's the pain point. But once you've found the pain point, so let's use bench press, for example, for this shoulder. Someone presents with bench pressing pain, and they're getting pain on the way down. They've got that pain, that typical pain at the front of the shoulder, and they're getting pain pushing off their chest. A diagnosis, a very typical diagnosis, could just be a shoulder impingement. So all that means is two bones banging together, there's a muscle in there, it's getting all jammed up. There may be a tear in the tendon, there may be a tear in the muscle belly, there could just be inflammation. Who knows? But there's a shoulder impingement going on. Now, this particular person has really developed lats, really developed internal rotators like the pec, the anterior delts, everything is pulling them forward. But something you've got to think about with that position for that person is that is a very functional position for them. That it's not by chance that they've gotten into these dominant patterns. They've been pulled into those positions because they actually create a lot of stability for them. So me, if I look at that and I go, okay, well, they're really limited into shoulder external rotation. I can't take their arm up overhead, so they're limited into shoulder flexion. And I go, okay, great, simple. Let's just smash their lats. Let's just, open up through their pec, and let's restore those ranges of movement. Now that makes sense in theory. And, that is a lot of what is taught in, physio degrees and, massage therapy courses. But the reality is it's very short-sighted, because with that is you've got your scap position, you've got your rib position, and if you've got to think about the body. There's always an opposing force. So if we're looking at the shoulder and we're looking at the lat, the internal rotators, the upper part of the shoulder, the traps, the scalenes, the neck muscles are often holding a lot of tension as well. So it's not like a single-minded, like, oh, they're internally rotated, it's the lats and the internal rotators. You've got to look at the opposite side of that as well. Because if you've got someone that comes in, and this particular person, they've got very dominant traps and upper shoulders, which is very common in like the powerlifting circle, there's a yin-yang relationship going on between the lats and like upper and lower essentially. So they're opposing each other. So hear me out. If someone has that relationship going on with their muscles and you just release the lat, all that tension is actually just going to move upstream into the shoulder. Now, if the shoulder was the component that was actually the more problematic side, releasing their lat is going to make them 10 times worse because you're going to put more pressure into the upper traps, the scalenes, the neck, which means by default, they're going to impinge more. So this is where you need to have a pressure testing system inbuilt before you go all in on treatment. So if, for instance, I had this person, I had them on the back, I could work through the lat, I could do some needles and stuff like that, but you would want to just start out with some soft tissue work, 30 seconds, 60 seconds, see if that actively changes them instantly. If it doesn't, keep looking. So go up to the trap, do a little bit of work on the trap, through the scalenes, see if by releasing down the neck, it actually improves range of movement and it improves their pain levels. That is the most important thing here. So if you're lucky and you do have a clinic that has equipment in there as well, you can go out into the gym floor, you can do a little bit of testing, go out, get underneath the bench press, do a few reps, see how it feels. And if it's been a really positive outcome from your hypothesis, go all in on it. Now, this is the other thing that I would highly suggest you do as well, is don't add too many signal in at one point. So say for instance, and I've made this mistake so many times it's such a good quality to have. When I first started out as a practitioner, I wanted to give so much value, but sometimes you confuse the signals. So if you've got someone's come in and you've figured out the area that's tight, you've released it, you get a really positive result. Don't add in a ton of stability-based exercises as well to try and offset that tension. Leave it, reassess next session, see how they pulled up from that particular session, and then you can continue to progress on. Just like a training program, you're not going to give someone the most complex exercise straight away. And if we view that progression within the rehab world in a similar lens, you're going to get a lot more out of it, but the patient's also going to understand it a lot more as well. So, they're going to have strategies and they're going to be able to, add things into their training programs and their warm-ups and their prehabs that actually carry over to real-time results. So with the shoulder, it is so dependent on stability. If you're taking input out, you want to make sure, or you're taking tension out, you want to make sure it's for the right reason. Because if you look at someone that's jacked, they're not jacked by chance. They've gotten jacked because they've done a lot of work. And that work has shown itself in the muscle, which is actually very helpful in a lot of cases until it isn't. Now, let's move down to, we're going to use bench press again for this example, but I want to move into the lower back, into the SI area. And it's such a common spot of pain for people, around that lower back. Now, say for instance, you've got someone, powerlifting and strength training is a sport of extension. Like you create so much tension into extension and you need that to keep you in a strong and stable position. So if you're having a look at someone that comes in and they're bench pressing and, they're getting their legs set in, they're getting their leg drive, they're getting the upper back arch and they're getting themselves into a really stable position. And often complaint is that they get pain just around that lower back, the top of the hip, that SIE pain. Sometimes it wraps, but it's, you can point to it. You know exactly where it is. Now, if you have a look at that, like a typical presentation of that, you may look at that and go, okay, awesome. They have a decreased ability to contract their glutes, decreased ability to contract their hamstring, and when they do a hip extension, their back just fires up and takes over. Great. It's not valid. Now, if we look, on the other side and we go upstream and we go, okay, well, let's look at the ribs. Do the ribs actually extend? Do we have rotation at the ribs? Is there enough room at the ribs and at the hips to actually create the position that you want? Now, often the missed component of this, and this is the example I'm giving just because it's bench, is your actual ability to extend your hip, to get your hip past your midline. So if you looked at it from a clinical presentation, you go, oh, well, this person's got jacked up erectors. They need some soft tissue work to take the pressure off the actual joints itself, and that will solve their problem. No, you've got to look above and below that as well. You've got to go, well, what's going on at the front of the hip? What's going on at the rib cage? Because often the tension that you have there is because it's working harder to try and control a range of movement. Now, if you think about it, your leg's got to go past your midline, past your body in bench press, well, optimally anyway. If you've got a restriction at the very front of your hip, like in your iliacus or your psoas or something, it's going to limit you from actually getting into hip extension. So yes, your back is tight. Yes, your back is getting compression, but it's only getting compression because it's having to work harder to create extension because your hip is lacking it. So I often see, if you're looking at these SI areas, is often that the actual SI itself is just treated, but you've got to pressure test your diagnosis. So you've got to add this one step in just to pressure test it. So in the example that I'm giving, you can just go in and you can do some soft tissue work. You could just do a little bit of soft tissue work through the iliacus. If you say, for instance, that's the area you're looking at, and you can release that up, get someone out into a bench press and get them into their normal position. See how the position holds up, because quite often you'll get an instant response. It's either like, yep, that's really good, or no, that didn't do anything. Then you have to keep looking. But without actually pressure testing it against a real life situation, it's very hard to say, yes, this is going to help. Now, primarily the people that I work with aren't just people that get out of pain, right? Like the bread and butter of the people that I work with are active lifters. So the strategy has to be a little bit more direct. You need to know that what you're actually doing is going to carry over to someone's position in the gym floor or when they're training, their actual pain mechanism. And, often we have pain, but often, if you think about the body, think of the body as one big system. All right. And there's 100% tension in this said system. And if you just, remove 50% of the tension, that tension's going to stay, but it's going to move somewhere else. So someone that's really active in the gym and actually has built an appreciable amount of muscle and strength, if you release something from the system, they're just going to then move that tension somewhere else. In some cases, that's a good thing. Like, let's just use, say my quads were really overactive and I release them. That then gives me an opportunity to get my hamstring, my glute, my posterior chain working. That's epic. But in the example I was giving before about the shoulder, if I release the shoulder, the lat, for instance, I could then further creep up into my shoulder, which then means that I'm causing further impingement. So when you're looking and you're working with these people, you need to make sure that what you're actually doing is having a positive carryover. It's not just, we've all seen the guy at the gym that goes in, or guy or girl goes into the gym and, just does their rotator cuff exercises. Like every single session they're doing it because they've been told that you have a weak rotator cuff. And, if you're internally rotated, all you need to do is work on your rotator cuff to, oppose that. That is just such a short-sighted view of, working with people when they're in pain. You're adding an input in that you're hoping has a carryover, but there's no, yes, there's some research papers. Yes, you'll have some clinical experience with it and seeing patients, but you need to pressure test it. You need to make sure that you know. So this, as a practitioner, even as a coach, if you're adding in some drills that you're intending to use to help with movement, pressure test your ideas first. There's nothing worse than throwing in a ton of inputs. The client doesn't get anything out of it. It just makes your diagnosis super confusing and not direct. So you would much rather spend more time diagnosing and figuring out exactly what you need to do, because treatment isn't hard. Treating the right thing is hard. So spend the time getting the diagnosis right, because it, when done well, will resolve most of your issues. Now, I hope you got something out of today's episode. I'll see you guys on the next one.